And then I'll hand over to Dr. Rosie Bronnett, who will talk about the State of the Nations report and the national recommendations. Then I'll come back with you to talk about the quality improvement resources that we have available to support you. And then we will go to the open forum and questions. So welcome to all of you. We have colleagues who are very familiar with NACEL on the call, and we also have colleagues who are not so familiar with NACEL, but hopefully towards the end, you will all have an idea about what we've done in 2024 and what the data has told us, and therefore what's informed the national recommendations. So I'd like to hand over now to Dr. Sarah Mitchell. Thank you, Sarah.
Thank you, Jess, and thank you for inviting me to present at the webinar. My name is Sarah Mitchell. I work clinically as a GP, and I'm National Clinical Director for Palliative Care and End-of-Life Care at NHS England. So I'm going to be talking today about the big picture related to England, but of course NACEL is much broader than that. I think what I'm going to talk about is probably relevant across the nations where NACEL is relevant. Because I work clinically as a GP, actually, I don't work in a hospital. I'm not somebody who does the data collection or engages with NACEL in my everyday work. So I've learned a huge amount about it since I've come into my post as National Clinical Director. And the first thing to say is a huge thank you to the team for all they do in driving this audit forward. I want to talk about the power and potential of the audit within the current big picture. Next slide, please. So for me, the big picture mainly relates, and the reason why we are all here is because of rising patient and population need for palliative care and end-of-life care. We know that in England, 1% of the population die each year, and we're anticipating that the numbers of deaths per year is going to increase really significantly to over 650,000 by 2040. And for me, the challenge in terms of this patient and population need relates to two things. One is that bit larger number of people living into old age who are approaching the natural end of life and require really good high quality end of life care. But the other is that more people are living much longer with their complex multimorbidity, highly individualized personal conditions and the associated symptoms that come with some of those conditions. And for me, those are people who really need robust, accessible, often highly specialist palliative care. So a double challenge for me. We know that of the people who die every year, 70 to 90% have palliative care needs, and we globally across the board have got a bit of a way to go in terms of identification of all those patients. Hot off the press, 56% of people in potentially in the last year of life or who have palliative care needs are now identified in primary care. So that's a little improvement from last year, which is encouraging. But there's so much more to do, and identification of needs in a timely way, of course, can lead to much more timely referral to specialist palliative care services and hopefully more equity of access to specialist palliative care where needed. And that affects us across whichever setting we work in. Please, may I have the next slide? So over the past couple of years, numbers of deaths in hospital have decreased by 1% each year since 2023, and that is something we can all feel really proud about. However, 42% of deaths still occur in hospital, so it remains a really important place of death. And this has a lot of attention in NHS England and the Department of Health and Social Care because the cost of that care can be quite high. Often patients have a journey including lots of unwanted admissions to hospital, emergency admissions ahead of that final admission. And you can see some of this in our NHS England dashboard here. Next slide, please. If we focus in on who is dying in hospital, the trend is worth attention. So I've put some red circles there around the most common cause of death in hospital is frailty. And we can see this association with people who live in the most deprived areas of England being potentially more likely to be dying in hospital settings. So that point about equity of access to palliative care is really, really key. Next slide, please. The next part of the big picture for me is where we are in terms of policy. So I hope that most people on the call who know a bit about NACEL will understand that some of the data collection relates to the priorities of care for the dying person, which came from 2015 and the review of the Liverpool Care Pathway. So the audit is really important in terms of us understanding that quality of care for the dying person in a hospital setting. Since More Care, Less Pathway, we've had the ambitions framework for palliative care and end-of-life care, which outlines for us in England, it's an England document, what good looks like, how we should be framing and what we should be aiming for in terms of high quality palliative care and end-of-life care for all people. In 2022, we had a really important inclusion in the Health and Care Act, where integrated care boards have a statutory duty to be commissioning palliative care services. So that is very broad, but there is a statutory duty for integrated care boards to be commissioning those services to meet the needs of their population. And that for us is an absolutely key lever, and people will have, I'm sure, seen and heard new policy guidance that's coming out related to where we want to be aiming to deliver care, and particularly around neighbourhood health. And I think this is, palliative care and end-of-life care for me should be absolutely central in terms of delivery of care in neighbourhoods. Next slide, please. The very big picture policy and the latest most important policy document that we have is the Fit for the Future 10-year health plan for England, and colleagues may already be familiar with the 3 shifts in care that document calls for. One is hospital to community, one is analog to digital, and the other is sickness to prevention. But for us, I think we need to be thinking about the relief of distress, prevention of distress. So suffering to prevention of distress. And there's lots of levers and room for improvement for us to be considering in the context of that policy document. Next slide, please. We also, in palliative care and end-of-life care, are in a highly political space at the moment. The Terminally Ill Adults Bill, as you are probably aware, is progressing through Parliament. It's just in the House of Lords, and they're having the second half of the second reading next week. Alongside that, we have the recommendations from the reports that are coming from the Palliative and End-of-Life Care Commission, and we are expecting a report from the Health and Social Care Select Committee later in the autumn. So this is a really political space to be in. So our work in palliative care and end-of-life care honestly has never been more important. Next slide, please. And that's where I want to come onto the power of this audit. Very often I hear people talking about NACEL, and I hear them talking about we must do this more in community hospice settings. And I do agree, in the long term, that would be amazing to aim for. But right now, the scope of the audit is hospital deaths. And the audit has power. The findings are powerful. They help us to understand what is going on. And the NACEL process and the quality improvement that it drives is also powerful. So the key findings I've just highlighted in some green boxes and red boxes here, because the green boxes really give us room to celebrate, actually. There's some really positive work happening out there. And we very often don't talk about the good bits, but the fact that 73% of bereaved people rate the care that was given to themselves and others by the hospital as excellent or good. It is brilliant. And those 77% agreeing that the dying person received sufficient pain relief during their final hospital admission shows, continual improvement, and we should be celebrating those findings. At the same time, the audit really highlights areas for much more focus for improvement. So I'm particularly interested in the personalised care and support planning conversations, because of course there is the care that's delivered in hospital, but we could be using that sort of finding to be informing whole system change, thinking about how on earth we really move forward with more personalised care and support planning conversations for all our patients who have palliative care needs and end-of-life care needs. I'm also interested in the 62% around evidence of communication about hydration, and the 41% about assessment of spiritual, religious and cultural needs, because that to me suggests that we've got some training needs to address for staff to build knowledge and confidence to have those conversations and do those assessments. So I think, while I agree that it would be great to extend the scope of the audit, we also have to have the conversation about making the most of the findings that we have here and the quality improvement that they are driving. Next slide, please. So you're going to hear in this webinar and hopefully have some great discussion about the recommendations that have come from the 2024 State of the Nations report. And I think they are very strong recommendations. I've obviously read them in detail several times. I want to highlight them because I think everyone could take them away and reflect on what they mean for them as an individual. The first recommendation relates to leadership and leadership, transparent, accountable leadership at provider and commissioner level. This for me is absolutely key in driving change. And I've put every system level because I think it doesn't matter if you're the leader of a team delivering palliative care or the leader of a national organisation delivering palliative care, your job is the same, to be an advocate for patients and to push forward in that wider policy context, patient population and policy context to drive change. All data that can help us make the case to improve access to specialist palliative care services 24/7 is so welcome, and the audit has that. Thinking about personalised care and support planning in the context of the 10-year health plan, I think it would be great for us to have a conversation about the context for personalised care and support planning, and my specific interest is in continuity of care. So continuity of care provided by a team, be that in a hospital or the community, and then critically how we join up that continuity across settings. More equitable care is really important area of focus, particularly as that terminally ill adults bill progresses through Parliament. And I think collectively, whether we're in hospital, workplace or the community, or preferably together, we can work to understand the communities we serve and then work on strategies to truly work in partnership with those communities to drive equity of access to palliative care and our services being more responsive to different cultural needs. And then increasing uptake of training. I think that the audit gives us plenty of areas where we could focus efforts around training. There are systems and processes in place like staff appraisal and personal development where we could have some more conversation about how to use existing resources, for example, the e-ELCA modules, to improve training and therefore improve care. So I hope that's quite a helpful summary of where I see the power and potential of this audit and how in a patient population policy and political context, I think we could be really focusing in on the audit findings and the drivers for change to have real impact for our patients. Thank you.
Thank you so much, Sarah. Really appreciate you attending and speaking. Next slide, please. So now that we've heard about the big picture, I just wanted to give you a little bit more detail about what NACEL 2024 looked like. Next slide, please. So as I said, many of you will be familiar with NACEL, but there are colleagues on the call perhaps who are not so familiar. And so I just wanted to tell you a little bit about the audit before we go into detail about the key findings and recommendations. So NACEL is a national comparative audit about the quality and outcomes of care, not only experienced by the dying person, but importantly, those that are with them by their bedside. The overall goal is to improve the quality of care where needed to the dying person and those important to them. And that's during the last admission to a hospital leading to their death. So the audit aims are to identify areas of action which can help inform quality of end-of-life care, reduce unwarranted variation, and that's through the benchmarking of outcome measures, as well as identifying and managing outliers, understanding and reducing health inequalities in relation to specified measures, and really critically sharing and adopting best practice and highlighting, showcasing quality improvement examples, signposting to resources and sharing successes together. Next slide, please. So NACEL 2024 had a relatively large sample size, but when we look at the number of deaths that occurred in England and Wales that stand at over 580,000, 252,000, just over, of those were hospital deaths. And so in the NACEL 2024 sample, we were able to look at 238 hospital sites, which makes up 99% of all eligible hospitals to partake in NACEL. We were able to capture information about 8% of hospital deaths. So that stands at a sample size of 20,954. We were able to capture information from bereaved people for 3% of hospital deaths. So that number was 7,354. And we were able to collect a really, really good sample size of staff reported measures at 14,406. So those were staff who were asked about their experience of delivering end-of-life care in hospitals. Next slide, please. So I'd like to hand over to Rosie, who's going to delve into the key findings and then the national recommendations. Thank you, Rosie.
Hi everybody, I'm Rosie Bronnett and I'm a palliative medicine consultant, but I'm also the NACEL Quality Improvement Clinical Advisor. And as Jess has said, we're going to go through the 2024 State of the Nation findings and recommendations. I think even though they're set out very clearly in the report, which is briefer than some of the previous NACEL reports, even though this is something that I do very often as part of my job here, I'm hoping that this will be a way to help us cement in our heads some of the things that are the most important from the findings, and then give you the opportunity to think about what you may want to delve back into in your local data. Next slide, please. So just a reminder that we have 10 primary drivers that we identified at the whole start of this NACEL process that we think impact on the quality of care that needs to be delivered to people who are dying in hospital and to those that are important to them. So this is available on our website if you want to go back to that again to try to help you focus on some areas that might be important for you. Next slide, please. The State of the Nation's report itself should have been circulated or has been circulated to all trusts, but it's in the public domain, so anybody can access it. If you haven't seen it, please do go onto our web page and find the State of the Nation report. There's lots of other helpful features which you can see in the outputs box that's included in this slide, where you can click on to find things. So for instance, the recommendations that Sarah has showed, there's a specific section on that. There's an infographic about the key findings at a glance and the key findings in a different way, which helps people process the information. And there's the public-facing patient and carers tool with some information for them about some of the findings. There's also an annual data sheet which goes through all of the data behind these recommendations, and that may be something that you want to look at if, for instance, as like my trust, you've been asked to produce an Excel file that you can look at some of the areas in more detail to track the assurance. So there's lots of things in that section that can be helpful for different people in different means. So do go and have a look at that section. New slide, please. Next slide, even. So we have 11 key findings because we couldn't settle on 10, and I'm going to go through them in a bit more detail now. Next slide. So the first is related to quality improvement plans. So all organisations, all provider organisations are encouraged to have a quality improvement plan related to end-of-life care. And in NACEL 2024, we found that 74% of these plans were shared with the ICB in the last 3 years. And that's of plans that were developed. So the number of ICBs that have a plan is slightly lower than that. It's worth just checking whether you do or don't have a plan and whether it's been shared locally, because that's something that you could do to help the system working that Sarah was talking about and we all know is important. Next key finding, please. Next slide. And access to specialist palliative care services. So we can see here, compared to when data was first available in 2019, that there has been some improvements, although it's quite static over recent years in terms of access to specialist palliative care. We know that we're in a very challenging environment in the NHS, and so I think monitoring this area for improvements as well as whether there's any deterioration in access is going to be really important over coming years. Next key finding. This is where you need to look at your individual data as well to help understand your picture specifically. So we found in NACEL 2024 that 83% of notes that were audited, the person was expected to die during their final hospital admission, and that there was a period of time between the recognition and death, which enables some of the important work that we know needs to happen during that time. There's also that information here in the second pie chart that if you weren't expected to die, but it wasn't a surprise, there's information about whether the staff recognised that the person was sick enough to die, and therefore the families and other people may have had some opportunity to prepare for that and staff to offer some of the things that may be important. Next key finding, next slide. We hear time and time again that hydration options and discussions about this is really important to families, and the NACEL 2024 data shows that this continues to be an area where care is challenging, and less than 2/3 of people have evidence of discussions around hydration options. So this is still something that remains a big issue in terms of the care that's being delivered within hospitals. Next slide, please. Pain relief is understandably very important, and there has certainly been lots of very difficult to hear stories of people's experiences in the media that have been used in debate and conversations nationally over the last year. And so it's really important to understand the national as well as your local picture around whether people have sufficient pain relief. As Sarah had commented, there are 77% of people who say that the person who died received sufficient pain relief. So that's the perception of their bereaved family member or friend who completed the survey. But that is a relatively positive finding, although we do find that 12% of people disagreed with this, and that would maybe something that people want to understand in more detail. But I think in the context of what has been discussed around nationally and in the media, it's helpful to be able to say that in many cases, people really do perceive that the person who died gets really good pain relief. Next key finding. This is another one of the areas where there certainly needs to be some attention, and that the NACEL 2024 findings are that there is significant scope to improve this. So less than half of people had an assessment, a documented assessment of their spiritual, religious and cultural needs. So understandably, this needs more attention, and it will be really useful to have a look at your local findings to understand where you sit and what things you may need to do if this is an area that it is also low in your practice. Next slide, please. So this relates to a question which asks a bereaved person to rate the care and support that the dying person received overall during their time in hospital and in the admission where they died. And it was rated as excellent or good in 75% of cases. So 3/4 of people thought that that was excellent or good. There was a very slightly lower proportion of people who thought that the care to themselves as a family member was excellent or good. And you can also see that there is a difference between the different settings here, with community hospitals having a much higher level of satisfaction with the care that they received than those people who were responding to people who had died in an acute hospital setting. Next slide, please. So this relates to personalised care and support planning and whether it takes place at all, but also whether it takes place during the final admission, during the admission, as well as being prior to the admission or prior to the admission, or no real evidence of personalised care and support planning. So this is suggesting that at present in hospitals, we aren't showing good evidence of personalised care and support planning either during their admission, or that there's transfer of that information from previously into their admission in hospital. And that is an area that then subsequently falls into some of our recommendations. Next key finding. So this relates to whether a person who dies in hospital has an individualised plan of care. Now, an individualised plan of care can be a prompt or a template, or it can be recorded free text in the notes, but where there's specific recommendations about how to provide certain aspects of care that are important. So most people who are assessed as having an individualised plan of care had it as a standalone template or prompt, whereas around 37% were documentations in the notes in general. Next slide, please. As part of our equitable care work and our work with our the group of people we've consulted with about how to look at this and address it within the NACEL data, there's been a focus for this period of time in NACEL at looking at equitable care with a lens of ethnicity. And one of the things that needs to happen in order to do that is to have some assurance about reporting ethnicity and to be ensuring that it is recorded regularly within the notes. So this shows that 86% of people's notes do contain a recording of a person's ethnicity. There are, however, 14% where it's either not stated or unknown. So there's still work for us to do to improve this information, which is really crucial to understanding how to look at things very, very simply from a lens of equity. Next slide, please. This relates to end-of-life care training, which is something that I think many of us will consider to be a really important part of helping equip our staff to be able to deliver good care. Only 62% of staff who responded to the staff survey reported that they had completed training specific to end-of-life care within the last 3 years. And it may be that that number is even lower, because it's most likely that people who complete the staff survey are in some way engaged in delivering palliative and end-of-life care. So that's our 11 key findings, and just a whistle-stop tour. You'll probably want to look at them in the State of the Nation report and look at your individual findings against that. But hopefully it just gives us a bit of a time just to process some of what we're seeing in the data. And one of the things we get told often, and is certainly true, is that the NACEL data set is huge, and thinking about what your practices relating to the 11 key findings is a really good place to start if you're not sure about which bits of the NACEL 2024 data to present or to look at going forward. Next slide, please. So we're now going to look at the recommendations in a little bit more detail, and then hopefully there'll be loads of time for us to ask questions, because there might be questions about the specific findings or the recommendations themselves, in which case we can go back to the slides. But I want to make sure that you have the opportunity to use the time as it is most useful for you. New slide, please. Next slide, please. So this is the slide that Sarah shared earlier. These are our 5 main key recommendations from the analysis of NACEL 2024 data. And they, as Sarah mentioned, they are something that we've come up with both by looking through the data, but also consulting very widely. So, for instance, with NHS England, thinking about our ICB colleagues, thinking about the education. So there are lots of different people that have been consulted in order to come up with the recommendations, as well as the team that are involved in NACEL themselves and our data analysts. Next slide, please. So recommendation 1 relates to the oversight of hospital improvement plans. Now this is trying to foster the cross organisational working that we know is going to be fundamental to delivering care, and has been, but it will be increasingly important. So its focus is trying to ensure that there's leadership both within an organisation and, well, in all sorts of different organisations. So in organisations that provide the care, but also in the strategic organisations, the integrated care boards or health boards, that there is commissioner level leadership, so that there is leadership in all of these different places to help try and coordinate a collaborative approach towards assurance and quality improvement that then focuses on delivery of good care. It encourages staff and in all of these different places to sign up and use the NACEL data improvement tool, because that is the quickest way to be able to look at your data in your locality and compare it in a slightly broader way, as well as to the national data set. And within that, there are 10 key indicators that you can look at, but you can obviously also look at these findings that we've presented today to ensure that they are that you understand that. So again, many people are already signed up to the data and improvement tool, but that is something that we would encourage even more people to do, because looking at that really does help you to understand the strengths and weaknesses of the care that you deliver locally. And as Sarah said before, it's really important to understand the strengths as well as the areas that need improvement, because we all need to know what we do well as well as what we need to do better. It also recommends that a provider ensures that there's sharing of this NACEL annual report to their ICB or health board. So if you're a representative of a trust and you haven't done that yet, then that may be something that you want to do. And ensuring that you have sharing of any quality improvement plans that you do have. Now, some of it is to try to drive up that finding about the number of organisations that have shared their quality improvement plans, and by having these as specific formal recommendations, it also helps organisations who've maybe found it harder to get into some of these conversations at a strategic level to have some leverage to be able to do that, and equally vice versa. If there are places where they have felt that trusts have not engaged with providing them, they can make requests to do that. Hopefully it will happen organically, and it will be a process that fosters good working relationships, but it also provides the opportunity, if there is a gap, for any party to be able to say, oh, it's recommended here. So do have a think about that from your local position. Next slide, please. Recommendation 2 is around access to specialist palliative care. So as has been the NICE Quality Standard 13 for quite a number of years now, there is a recommendation that there should be face-to-face specialist palliative care availability 8 hours a day, 7 days a week, with a 24-hour, 7 days a week telephone advice service. And this recommendation is to try to ensure that that remains a priority, because without access to timely specialist palliative care, when people who don't have those specialist skills have identified problems and need help finding solutions, then that may not be available quick enough for the people that need it. It's also about recognising when there are gaps trying to think about what are the workarounds, how can we manage things as best as we can, what are the services that can be used, and trying. I think this remains something that palliative care is very committed to nationally, but we know that that it's such a tight financial climate that it's really difficult to be asking for more time and more staff at the moment. And we hope that by keeping this as a priority recommendation, people will have the platform to be able to continue to ask. Next slide, please. Improving personalised care and support planning is our third recommendation. And this is about trying to understand your local practice in more detail and then work collaboratively to improve it. I think Jess will talk just a little bit later about the good, or may have done, about the Good Practice Compendium, which is a summary of some of the great quality improvement work that we have collated together. But there are examples within that about people who've done work around personalised care and support planning, and that will be something that we continue to build on as we get more examples of things in the future. This tries to help ensure that there's visibility coming in, but also recognising that in order to do things well, it also requires hospital-based staff to be able to have conversations and think about this personalised care and support planning, because not everybody who comes into hospital and dies is that anticipated before they come into hospital. And ensuring that there's some monitoring on any improvement work and implementation around this area to try to really help ensure that people don't feel that they have to repeat all of the difficult conversations for them, but that we really do work on having continuity of care that's personalised to the person themselves. Next slide, please. Recommendation 4 relates to equitable care being delivered for all dying people. And it's, again, designed to be a recommendation at a strategic level, thinking about understanding your local population, how well completed your data is. Are there differences in the delivery of care that you have in your local population that relates to different groups of people? The NACEL data enables you to be able to do that for people by age group or people by ethnicity, with some filters within the data to try to help you understand that. And this recommendation is that having a very active understanding of what care looks like for different groups of people will be really important to help understand how to make it better for those people where they are not having as good a care as they need at the moment. So this encourages us to be thinking strategically and delving into the data to try to help that. Recommendation 5 is on our next slide, please, and that relates to training and support. So many of these different areas that we've talked about do have an element of education that underpins that. And again, this encourages there to be a system-wide approach to training and support, and we have highlighted that the NACEL data suggests that some of the areas that continue to need focus are around recognition of dying, pain management, discussions about drinking and hydration, and the assessment of spiritual, religious and cultural needs. But you may find from your own individual data that there are other areas that come across really clearly there. And then this encourages there to be strategic planning for the delivery of training around this rather than ad hoc sessions. And again, that to be part of how to plan sustainable training for the wider workforce. And that includes obviously ensuring that there are sufficient staff for that delivery. Next slide, please. So that's the sort of a whistle-stop tour of our main findings and recommendations. I've seen that there's some questions in the chat, and we can come on to them as we get to the end of the section, and we'll certainly will have a look at that. So I have seen, and we'll come back to that, but for now I'll hand back over to Jess to talk about the supporting resources and QI outputs, and then I look forward to hearing the conversation and questions in a few minutes.
Thanks so much, Rosie. So before we get on to the discussion points, we just wanted to kind of share with you what we have put in place to help support quality improvements. Next slide, please. So, as I said, some of you might be quite new to NACEL, and some of you will be very familiar with NACEL. Sarah and Rosie both spoke about the power of the recommendations and how many different stakeholders were involved in putting them together. And so if you're not sure with where to start with quality improvement, we really hope that the national recommendations give you that leverage and that platform, as Rosie said, to have a look at your local data and use those national recommendations as a starting point to identify your areas for quality improvement. However, of course, you will all have system, regional and local priorities and pressures that need to be responded to. We very much hope that they somewhat align with the national recommendations or the key findings, or both. But of course, your local data will be the thing that should steer where your quality improvement priorities should be. And so looking at your local data through the data and improvement tool, alongside any other local data that you may be collecting, perhaps you run local audits, or perhaps there's some other local data that drives your improvements, that obviously will be a really important thing to consider when you're looking at your improvement priorities. And of course, many of you will have feedback sources, including patients and family, or complaints and compliments. And so altogether, we really hope that they can be triangulated to help inform what you do quality improvement. Next slide, please. Here are some featured quality improvement outputs that the NACEL team have put together. So firstly, the data and improvement tool. Many of you will already have access. Some of you may not have access, and for some of you, you may not be able to get access. You may not be working for a provider organisation or in an ICB, in which case there is a different tool that we can show you in just a little while. We also have two compendiums that we've developed new this year. They are the Good Practice Compendium and the Impact Compendium, which I'll show you in a little while. And then we've got lots of resources on our website, which we call the NACEL portal, which I'll just briefly talk you through in a minute. Next slide, please. So if we start with the data and improvement tool, next slide, please. This tool is how all of your data is presented back to you. It's an interactive tool that helps you interrogate your data through 3 different views. This first view that you see here is what we call the dashboard view. So this takes the 10 key areas of NACEL that Rosie showed you at the beginning. They're taken from our driver diagram, and they sit along the top of that diagram that is on the PowerPoint. And for each of those areas, you have a dashboard breakdown of the data that relates to that area. And that data is taken from all of the data sources for NACEL. So you will have data taken from the case note review, from the bereavement survey, from the staff reported measure, and from the hospital site overview, as they are appropriate to those areas. You also have another section on that dashboard called your key indicator summary. The key indicator summary is meant to be quite a high level view of NACEL. So it is 10 metrics as standalone metrics that represent the entire audit. And as I say, is meant for a high level audience. Next slide, please. The second view that we want to show you in the data improvement tool is the Explorer view. So for each of those 10 areas of care for NACEL, they are broken down into different aspects of care. So for example, if you were interested in looking at recognition of dying and you wanted to understand what expected deaths and unexpected deaths looked like in your hospital, you could have a look at that in the Explorer view, and you could also filter that data by various different aspects, for example, age, ethnicity, or whether which staff feedback group related to that area. You can also compare your data on that view as well. Next slide, please. And the final view is the Explorer view. Sorry, the previous view was the overview, and this is the Explorer view, which includes a time series. So in this Explorer view, you can see where you benchmark to other providers, but you can also look at a time series. Next slide, please. And that hopefully is quite helpful if you are looking to put in place a quality improvement intervention and you want to track your intervention and how your data responds. Hopefully this time series view is quite helpful to do that. So that's the data improvement tool, and that will be helpful for those of you that have access or that are able to get access. But as I mentioned, there are colleagues and people who are interested in end-of-life care in hospitals that will not be able to access this tool. And in that case, can I have the next slide, please? This year, we released a patient and carer tool. This is completely publicly available, so anyone can look at this on the NACEL website. And this has 5 different metrics that have been selected in co-production with a bereaved persons focus group. So these 5 metrics can be broken down across England and Wales and can also be broken down by region. And this is a tool that is in development. And next year we will be looking to develop this to aggregate down to hospital level data. And that will be another co-production exercise alongside colleagues. Next slide, please. So that was the first sort of in focus area that we wanted to show you, the data and improvement tool and the patient and carer tool. I just want to draw your attention now to the resources that we have available on the NACEL portal, the NACEL website. There are lots of different resources that we have available on there, so your best bet is to go on and have a look around. But I wanted to draw your attention to a few things on there. Firstly, Rosie mentions the driver diagram, and that underpins everything that we do in NACEL. So that's a very handy diagram to look at, particularly as you start to develop your aims and your measures for your quality improvement work. We're just finishing off writing the healthcare improvement plan, which will bring together the recommendations along with 5 national goals that we wish to work towards to improve end-of-life care across hospitals in England, Wales and Jersey. So that will be released soon. On the website is also a mapping document. The mapping document takes every single question that we ask across NACEL and across each of the 4 areas, and we map those questions to our 10 key drivers. So if you are particularly interested in improving recognition of dying in your hospital, it would be really good to look at the mapping document and see exactly what questions are asked that can answer about recognition of dying across all 4 aspects of the audit. We have various different quality improvement tools that we signpost you to, and that is the picture on the right-hand side. We take you through the 6 stages of quality improvement, and we signpost you to different quality improvement tools that you can download. Some of them are templates, and hopefully some of them can help inform your quality improvement project. Always check with the hospital that you work with whether they have their own templates that they prefer to be used. And finally, we have some examples of reporting templates. So these are examples that are taken from hospitals that have reported to various different levels. We have anonymized them and created templates for you to download, enter your own data into, so that you don't have to duplicate work that has already been done. Next slide, please. As I mentioned, there's 2 compendiums that are newly developed for this year. We have previously had compendiums, but these ones are different because they are interactive, and you can select via theme or via quality improvement intervention. So there are 68 examples taken from information that hospitals gave back to us in the hospital site overview. There are case studies in there that have been themed. So for example, if you're particularly interested to see how to improve things in the emergency department, there are case studies that you can pull up to look at what other people have done. They've also been themed by quality improvement interventions. So if you're particularly interested to see what education interventions people have used, you can again select the intervention of education and you can pull up case studies. If you're interested to get in contact with anyone, then you can just drop us an email and we can do what we can to put you in contact with people that have run those case studies. Next slide, please. I'll just give you 2 minutes to read some examples that have been taken from the Good Practice Compendium, highlighting different aspects of improvements. And next slide, please. So the second compendium is called the Impact Compendium, again taken from the information we got back from the hospital site survey when we asked hospitals to tell us how NACEL has impacted on their service. Again, that their responses are themed. So if you're particularly interested in understanding how other hospitals have used NACEL as a tool, for example, you can select that as a theme and that will pull up the case studies that have answered how they've used NACEL as a tool. Again, it's an interactive page and hopefully is helpful in sharing learning. Next slide, please. And here's some extracts taken from the Impact Compendium. All of our slides will be shared on our websites at the end. Next slide, please. And so finally, I just wanted to draw your attention to events that we run throughout the year. We will be running 3 more webinars next year, and they will start from spring. But to finish this year off, we have 2 data and improvement drop-in sessions that are running this month and next month. So if you're not familiar with the data and improvement tool, or if you're getting stuck on a particular aspect, these are sessions that are really informal. You can just drop in. We can help you problem solve and hopefully help you get to where you need to be with the data and improvement tool. And we're also running a warm-up event for NACEL 2026 in October next month. So we will be going through with you what NACEL 2026 will look like and the changes that have been made. Next slide, please. So very finally, and thank you so much for your attention and sticking with us, just some next steps, and then we will open the forum for discussion. Next slide, please. So please access the data improvement tool if you're able to. Please visit our NACEL portal pages for QI and have a look at what we have available for you to support your quality improvements. Have a look at both of the compendiums. Watch out for the release of the Healthcare Improvement Plan, which will pull together the recommendations with 5 national goals. And please sign up for the next events on our events page. So if I can just please ask for the recording to be stopped, and if I can please just share the QR code for the evaluation.